I was diagnosed with polycystic ovarian syndrome when I was 22, which is a hormonal disorder. It causes infertility.
How's that impacted the relationship positively and negatively?
We're going to a fertility doctor and I'm on fertility meds and I respond well to them, but still not pregnant. And we've been with him for 8 years.
Tell me about your sex life.
Gosh, we hardly ever have sex anymore.
So I suffer from infertility and I've had 3 miscarriages now. And so I just want to share my story in hopes that it will help someone out there who is struggling on your own personal infertility or miscarriage, pregnancy loss journey.
To be honest, when my doctor told me I had it, he sort of just sent me away and I didn't really know what to expect. And then it wasn't until I then got my periods that I started to notice the first sort of side effects where I think I had 1 period and then I waited another year for my next one.
So PCOS appears in a lot of different ways for different people. Some people might be experiencing lack of ovulation, really long cycles, no period, hair growth on the face, chest, back, places that they normally would not have hair growth, balding, weight gain around the belly, a lot of different ways, polycystic ovaries. There's a lot of different ways that PCOS presents itself.
PCOS or polycystic ovary syndrome is linked to insulin resistance. In fact, it is believed that insulin resistance in polycystic ovary syndrome is caused by the underlying mechanisms contributing to polycystic ovary syndrome. First of all, PCOS is a condition where women do not produce the proper amount of sex hormones.
We're talking about a medical condition now which affects at least 1 in 10 women, but just isn't spoken about enough.
Polycystic ovary syndrome, or PCOS, alters the way the ovaries function, which can lead to both physical and psychological symptoms. It can often be hard to spot and even harder to manage.
You've been tracking your cycle for a year. You've done the ovulation tests. You've taken the folic acid. You eat well. You don't smoke. You do everything they tell you to do, and it still isn't happening. Your doctor checks your blood work. Everything comes back normal. What your doctor didn't check, your fasting insulin, because there is a hormone, not a reproductive hormone, that may be quietly blocking your ovulation every single month, and most women trying to conceive have never heard of it. That condition is called insulin resistance. Today we go there. Before we begin, this video is for educational purposes only. It is not medical advice. Please consult your healthcare provider about any concerns regarding your fertility or metabolic health. The fertility conversation almost always starts with the same hormones: FSH, LH, progesterone, estradiol. These are the reproductive hormones, the ones your OB/GYN measures, the ones that get checked when things aren't working. But there is a metabolic hormone that sits above all of them in the command chain, a hormone that signals to your hypothalamus, the master control center of your brain, whether your body considers it safe to reproduce right now. When that hormone stops working correctly, the entire reproductive axis can quietly shut down. That hormone is insulin, not because you have diabetes, not because you eat candy all day, but because insulin resistance, a condition affecting an estimated 1 in 2 women of reproductive age, is one of the most common and most underdiagnosed drivers of ovulatory infertility. The science on this is not new. It is just not reaching you. Let's start with the basics. What does insulin actually do? When you eat carbohydrates, your blood sugar rises. Your pancreas releases insulin, a chemical signal that tells your cells, absorb this glucose. Use it for energy. In a healthy system, your cells respond. Blood sugar comes down. Insulin returns to baseline. In insulin resistance, your cells stop listening. The signal gets ignored. Blood sugar stays elevated. Your pancreas pumps out more and more insulin, trying to force the message through. The result is chronically elevated insulin in your bloodstream, a state called hyperinsulinemia. A 2024 review in Frontiers in Endocrinology confirmed what researchers have been tracking for decades. Hyperinsulinemia directly disrupts the hypothalamic-pituitary-ovarian axis. That axis, your HPO axis, is the command chain from your brain to your ovaries. When insulin is chronically elevated, it interferes with GnRH, the hormone your hypothalamus pulses to trigger the ovulation cascade. No proper GnRH pulse, no LH surge, no egg released. And here is what makes this so difficult to detect. You can have normal fasting glucose, normal A1C, normal on every standard test your doctor orders, and this process can still be happening silently in the background. Now, let's talk about PCOS, polycystic ovary syndrome.
PCOS is a hormone disorder that causes you not to ovulate. Now trust me, PCOS gets commonly misunderstood. And one of my biggest pet peeves as a fertility doctor is that many people out there who are not as trained as myself, or maybe who just don't understand the physiology of PCOS, they will actually tell you that this is a problem of having low progesterone.
It affects between 8 and 13% of women of reproductive age. It is the leading cause of ovulatory infertility in the world. And most people, including many physicians, still think of it primarily as an ovarian condition. It is not. PCOS is, in the majority of cases, a metabolic condition with reproductive consequences. A 2025 study in the Journal of Endocrinology found that hyperinsulinemia worsens PCOS reproductive symptoms by exacerbating pituitary hormone imbalances and increasing levels of bioactive androgens, male hormones.
Endocrinology is a very fascinating area of medicine, and we study the function of hormones and the glands that secrete those hormones.
Translation: chronically elevated insulin raises testosterone. Elevated testosterone skews the LH to FSH ratio, the hormonal balance your body needs to drive ovulation. The follicles begin developing. They just never fully release. That is what the so-called cysts on a polycystic ovary actually are. Not true cysts, but partially developed follicles that stalled. The driver, in the majority of cases, insulin, which means treating only the reproductive downstream, with clomiphene to force ovulation, or IVF when that fails, without addressing the underlying metabolic condition is, at best, treating the symptom. Here is the piece almost no one connects in the fertility conversation: sleep. Not just because rest matters for well-being, but because of what chronic sleep disruption does to insulin. Disturbed deep sleep, the slow-wave sleep phase, keeps cortisol elevated into the following day. Cortisol is insulin's direct biological antagonist. It raises blood sugar even without any food intake. The chain: poor deep sleep, elevated cortisol, elevated blood sugar, elevated insulin, suppressed GnRH pulses, disrupted ovulation. Among women in the 25 to 40-year window, the primary trying to conceive demographic, fragmented sleep is one of the most common and least addressed metabolic risk factors. Your fertility and your sleep are not separate systems. One is downstream of the other. When insulin-driven PCOS is diagnosed, the standard medical protocol involves 3 options: clomiphene, to override the hormonal disruption and force ovulation; metformin, a diabetes drug that reduces insulin output; and IVF, when the first 2 are insufficient. These are not wrong. A 2025 study in Frontiers in Endocrinology found that metformin significantly improved pregnancy outcomes even in non-PCOS women with insulin resistance and recurrent implantation failure. But none of these address why insulin resistance developed. And for many women, the underlying metabolic dysfunction remains, meaning the same mechanism that disrupted fertility in the 30s continues operating into the 40s, 50s, and beyond. The research question that is increasingly being asked: what happens when you address the root metabolic cause alongside medical treatment? The data is beginning to answer that. 5 interventions have consistent evidence in peer-reviewed literature for improving insulin sensitivity and, through that, ovulatory function. First, reducing the carbohydrate load, not eliminating carbohydrates, reducing the glycemic burden. A 2023 study examining IVF outcomes in PCOS patients found that lowering HOMA-IR, the standard index of insulin resistance, significantly improved ovarian response and reduced early miscarriage risk, the most direct non-pharmacological way to lower HOMA-IR. Reduce the frequency and size of insulin spikes through dietary carbohydrate reduction. Second, time-restricted eating. Eating within a consistent 8 to 10 hour window gives insulin levels time to fully reset each day. Continuous grazing, even on healthy foods, maintains chronically elevated baseline insulin. Third, targeted deep sleep, not just duration, specifically protecting slow-wave sleep. This is the phase where insulin sensitivity is restored overnight, where the HPO axis resets. Consistent sleep timing, cool room temperature, and avoiding late evening light exposure all increase slow-wave sleep proportion. Fourth, myo-inositol, A 2024 clinical study published in Curious found that myo-inositol, a naturally occurring compound, significantly improved insulin sensitivity in women with PCOS. HOMA-IR improved meaningfully, and around 68% of participants restored regular menstrual cycles. Fifth, N-acetylcysteine, NAC. A 2025 systematic review and meta-analysis in Nutrients found that NAC significantly improved progesterone levels and endometrial thickness in women with PCOS.
Without cysteine in the body cannot synthesize, mostly in the liver, the glutathione that it requires. NAC, or N-acetylcysteine, is an amino acid. It absorbs very well orally, and it is the rate-limiting or main effector of our formation of glutathione. And so a lot of clinicians and a lot of lay people will use N-acetylcysteine to try and increase glutathione levels in the body.
NAC acts as a precursor to glutathione, the body's most potent endogenous antioxidant, reducing oxidative stress in the ovarian microenvironment, alongside insulin sensitization effects. If you are discussing supplements with your healthcare provider, both myo-inositol and NAC are among the more evidence-supported options for insulin-driven reproductive dysfunction. Always consult your doctor before starting any supplement. Standard fertility panels do not routinely include insulin markers. Here are the specific tests worth asking about at your next appointment. Fasting insulin, not just fasting glucose. Glucose can remain in the normal range for years while insulin is chronically elevated. HOMA-IR, calculated from fasting insulin and fasting glucose together. It gives you a direct index of insulin resistance severity, free and total testosterone, elevated in the majority of women with insulin-driven PCOS. LH to FSH ratio. In insulin-driven anovulation, LH is often disproportionately elevated relative to FSH. You are not diagnosing yourself. You are walking into your appointment with informed questions. That is what the science can do for you that a 10-minute consultation often cannot. Here is the larger picture. Insulin resistance does not only affect your fertility window. Decades of research now link chronic hyperinsulinemia to cardiovascular disease, cognitive decline, and accelerated biological aging. The same metabolic dysfunction that may be disrupting ovulation in your 30s is the same mechanism, left unaddressed, that increases Alzheimer's risk in your 60s and 70s. What you do now matters beyond this decade. The generation of women in their 20s, 30s, and 40s today may be the first to reach 90 in genuinely good metabolic health, but only if they understand what the science already knows. Fertility is one window, but it is one of the most important early warning systems your body has. If you want to take this with you, we've put together a free visual map of everything we covered today, the lab values, the mechanisms, what the research found, all on one page, printable, shareable. The link is in the description. If you found this useful, subscribe, because this is exactly what this channel is for, showing you what the science says so you can walk into your doctor's office and ask the right questions.